Depression is a very severe medical ailment and it needs the medical intervention. If it is not medically intervened, the person may have these suicidal thoughts, and that is quite debilitating for the person himself or herself, and as well as for the close relatives and the family. So we're going to help the person. The correct diagnosis is again the mainstay over here. How, after the clinical presentation, after the patient presents to you in the OPD, how are you going to diagnose that a person is suffering from depression? Whether it's just the feeling of unhappiness, or if you're going to label that person as having a depressive episode. So it's very important, because it is how you're going to assess whether you're going to classify that person, he's suffering from the milder form or he's suffering from the severe form of depression. It's the mainstay over here. And in this section, we'll be discussing with the assessment as well. The mild, moderate, or the severe forms of depression, they're going to be discussed over here. And what are the ICD's classification of this disease? So these are the mainstays over here. The first diagnosis of depression is very important, and that is going to be very crucial. Working as a clinical psychiatrist, as a working, practicing psychiatrist, you should know how to label a person as having depression, or whether he is just having a feeling of unhappiness for a very short period of time that can go away without the medical interventions. So the assessment and differential diagnosis is very important over here, and we're going to discuss what are the differential diagnoses, what the person can have other than depression and still having the same sign and symptoms of depression. The etiological models of depression are very important. The causative factors and the risk factors, we've already gone through them in details, and we're going to discuss what are going to be the basic etiologies, and the modeling of these etiologies is again very important over here. The first diagnosis of depression is usually made in the older depressed people, and it is less likely the diagnosis in the primary care. So usually these older individuals are found in the nursing homes, and they are more prone due to that clustering phenomena that is usually seen in these old homes. So the somatic presentations, they may hinder the diagnosis as well. And then there are the non-specific symptoms on the other hand, including the headaches. And then we can have the lower back pain as well. And the person may complain of weakness, inertia, or chronic fatigue, or tiredness. These are basically all of the signs and symptoms. And then the person even may have the physical symptoms. And this phenomena is basically known or marked as the Munchausen syndrome, in which the person has a fictitious disorder that he's suffering from a specific ailment, and upon investigation, upon the lab investigations, you come to know that there is no physical ailment as the person was thinking about that. So the assessment again is very important, and the complaining of the affective disturbances is done, and it is very important to maintain a high index of suspicion, and the diagnosis is made on the basis of a complete history, and the history is taken from the patient as well as from his friends and his family, and the mental state of that person is also noted down. Has there been any significant event, significant bereavement in his life? It's again very important, because it can be a phenomenon of the post-traumatic stress disorder. The corroborative history is taken. It's very valuable, and equating mood with the anger or irritability. Sometimes the anger or irritability is confused with depression, so that should not be the case. Then the checklist of depressive symptoms is very important. You have to inquire about the mood and sleep. So if there is some disturbances in the sleep, the person tells you that his normal sleeping hours have been disturbed. So that is going to mark the mood disturbances as well. There can be a diurnal variation in the mood. So that is very important over here. Then the person may also tell you that he has a decreased or an increased appetite. So it can be an increased as well as a decreased appetite, and as may be the case with the weight of the person as well. Then he may have the anhedonia. So anhedonia was a terminology which basically means the loss of interest or enjoyment. in activities which he previously found quite joyful, and now he doesn't feel any interest or enjoyment in those activities. There's a lack of energy or motivation. So it's again another phenomena which is known as inertia. Although he is physically fit and he doesn't have any physical problems or physical issues, but still he'll give you a history that he has no energy, or he feels as if he has lost energy to do anything, and that is going to affect his day-to-day life. The diurnal variation in the mood is again very important, and then he's going to lack that concentration. The concentration span is going to be affected in such individuals as well. So the areas to consider in history are the recent life events, the difficult ongoing life circumstances, and it can be the more distant participants. For example, any trauma from the childhood can even affect the present life. So a complete and a detailed history is again very important over here. Then previous episodes of depression are again very important, and the family history of psychiatric disorders is again very important. It can be taken from the close relatives, and even it can be taken from the friends of that person. The recent physical health is again very important, and we have to have the complete history about the comorbid psychiatric conditions. For example, the person may have the anxiety or the phobias or the anger management disorders. So all of these are basically the comorbidities that can persist with this psychiatric disorder that is called as depression. So the mental state examination is very important over here, and we are going to see and look for the signs of self-neglect. The personal hygiene of that person is again very important. Whenever you get a general look, even you can tell by the general look of a person whether he is taking care of himself or herself or not. So the personal hygiene is very important. The weight of the person is very important. The look on his face is very important. So look at your patient very carefully to diagnose a condition. The psychomotor changes in the terms of retardation are again very important, and we have to look for them. Agitation, fidgeting, or restlessness. When you observe a person, you can see whether he's in a state of calmness, whether he is quite concentrated in his work or not. Any fidgetness can be noted down, and restlessness can be noted down while you're taking the clinical notes and you're taking the history, and side by side you can take down the clinical notes on your writing pad. So the tearfulness or the irritability is another phenomena. The uncharacteristic tearfulness that is not associated with any event that is in the current situation, and he may feel to cry even if there is not a situation which is sad enough that you have tears in your eyes, but still he's going to have that feeling of crying. So that irritability and crying feeling is again very important over here. The differential diagnosis has to be given at this point, and the overt psychological symptoms. There can be a stress reaction, which is usually a common diagnosis. The brevity of symptoms are again very important. The differential diagnosis of more severe symptoms has to be given. For example, the anxiety disorders and dysthymia, they are going to be noted down while you're writing down the history of such an individual. The alcohol misuse, if you get the history in the past history or the drug history. The dementia in older patients is very common, and usually the patient presents that he has that forgetfulness even of his day-to-day activities. Eating disorders, especially the younger females, for example, they're going to have the anorexia nervosa or the bulimic disorders, and they're going to be the highlights of depression in such an individuals. Then we can have the hypothyroidism, which is also marked by depression, and the adrenal dysfunction. So the hypothalamic pituitary adrenal axis, the dysfunctioning of this axis is again going to be the etiology behind that depressive episode. So the psychodynamic or the interpersonal disorders can emphasize the importance of loss, and it can be the loss of self-esteem, and it can also be the disturbed emotions and the relationships on the other hand. The cognitive disorders can be the primary causes, and the person is going to have the negative thoughts in such a case. The pessimistic expectations are going to be found, and there's going to be the withdrawal in the self-perpetuating pattern. The neurotransmitters, such as the disturbed neurotransmitter function, and the examples can be the depletion of tryptophan. It can even present as a depressive episode in an individual. So in this section, basically, we dealt with the different factors. How are we going to assess an individual when a person comes up to you and give you the history that he has had depression? How are you going to diagnose whether he has the milder form or the more severe form? So that is the end of this section. Thank you for watching sqadia.com.